and good afternoon and good evening for all others who are joining from the rest of the world. Today, our guest speaker for the day is Professor Fadi Fakhari from Switzerland. He's going to lecture us today on how do I diagnose and treat atypical hemolytic uremic syndrome. This webinar is brought to you by Mumbai Hematology Group, supported by Nirvin Life Sciences and managed by Perfect Square. I thank Mr. Paresh Prabhu Gaonkar and team Nirvin, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Sanjeev from Lucknow, our guest speaker for the day, Professor Fadi Fakhari from Switzerland, all our discussants who are themselves eminent hematologists and nephrologists, and you participants for sparing your Sunday morning, afternoon, and evening. Next Saturday, that is on 6th of May at 7 p.m. onwards, we have a lecture on ASH updates in CML and myeloproliferative neoplasms by our guest speaker, Dr. Vivian G. Euler from Seattle, USA. And the following day, that is on 7th of May, Sunday from 11:30 a.m., we have a lecture on 2023 update on T-cell lymphomas by our guest speaker, Professor Brunangelo Fellini from Perugia, Italy. Let me introduce our discussants for the day and here displayed in alphabetical order. To start with, we have Dr. Abhijit Baheti from Dinanath Mangeshkar Hospital, Pune, Dr. Ami Patel from Shashwat Super Speciality Center, Surat, Dr. Dhyaneshwar Upase from New Life Hematology Center, Wakad, Pune, Dr. Hasmukh Balar from Surat Hematology Center in Kiran Hospital, Surat, Dr. Kunal Goel from Tata Memorial Hospital, Varanasi, Dr. Ranjit Matthew Varghese from Kaman Hospital, Pune, Dr. Reshma Roshan from Sher-e Kashmir Institute of Medical Sciences, KIMS, Srinagar, Jammu and Kashmir, Dr. Samir Malinkuri from Dinanath Mangeshkar Hospital, Pune, Dr. Sandeep Bartake from Bharati Vidyapit Medical College, Pune, Dr. Sushil Selvarajan from Christian Medical College, Vellore, Dr. Swekar Lankad from Avinash Cancer Clinic, Pune, and Colonel Dr. Uday Yanamandra from Armed Force Medical College, AFMC, Pune. Now it's a time to introduce our special guest for the day. Here with us, Dr. Sanjeev. Dr. Sanjeev is DM in Clinical Hematology, PDCC Hemato-Oncology, and Associate Professor at Department of Hematology, SGPGI, Lucknow. Dr. Sanjeev is a hematologist, hemato-oncologist, and bone marrow transplant physician. He has a very special interest in hemophilia and bleeding disorders. He did his DM in clinical hematology from SGPGI Lucknow in the year 2015. He did his PDCC hemato-oncology from SGPGI in the year 2012. Earlier, he did his MD in general medicine from VSS Medical College, Bulla in 2010. He was also the consultant at BGS Global Hospital. He is a member of European Hematology Association, Indian Society of Hematology and Blood Transfusion, American Society of Hematology, Indian Society of Bone Marrow Transplantation, Indian Myeloma Group, and European Bone Marrow Transplantation. It's my privilege to invite him to inaugurate our webinar and give some words of wisdom. Over to you, Dr. Sanjeev.
Thank you, Dr. Amit. Thanks for MB Agrawal, sir, for organizing this Mumbai Hematology Group meetings. These meetings are definitely academic feast for all of us, all the hematologists. Our resident learn a lot from these meetings, and these meetings are of international standards. Thrombotic microangiopathy cases are our frequent nephrology consultation, and without wasting time, I will request Dr. Fadi to please start his lecture. Thank you.
Thank you, Dr. Sanjeev, so much for your words of wisdom. Let me share the screen again. Once again, thank you, Dr. Sanjeev, for your kind words of wisdom. Now I invite our guest speaker for the day, Professor Fadi Fakhari from Switzerland. Professor Fadi Fakhari works at Department of Medicine and Service of Nephrology and Hypertension at Lucerne University Hospital, University of Lucerne, Switzerland. He's an adult nephrologist and a clinical researcher. He has a long-standing interest in autoimmune renal diseases, particularly complement-mediated nephropathies. He has conducted several clinical and experimental studies in the field of thrombotic microangiopathies, C3 glomerulopathy, and other membranoproliferative glomerulonephritis. He's going to lecture us today on how do I diagnose and treat atypical hemolytic uremic syndrome. Well, thank you so much. Over to you, Dr. Fadi Fakhori.
Thank you so much for the invitation. Let me share my screen. If I can, it's here. You can see my screen?
Yes,
now.
sir. You can see your screen.
Okay.
You can put in full mode, sir.
Yeah. Thank you for the invitation. I'm very pleased and honored to speak and discuss with you the issue of atypical HOS as you asked me to do. So, thrombotic microangiopathy, as you know, is rather a pathological definition with a wide spectrum of features in pathology features, and the organ that provides the most frequently pathological details and pictures of TMA is the kidney. And within the kidney, the thrombotic microangiopathy features range from widespread thrombi to just swelling and detachment of endothelial cells in arterial and glomerular. And as you all know, went too far. Thrombotic microangiopathy is a disease of the endothelium that in this setting, endothelial cells acquire a prothrombotic and pro-inflammatory phenotype, leading to thrombosis and aggregation of plaque. And today we're going to focus on a special type of thrombotic microangiopathy called hemolytic uremic syndrome that has a peculiar and very special interest in the kidney. And we don't know why this type of thrombotic microangiopathy affects predominantly, if not exclusively, the kidney. And as you all know, there are several types of hemolytic uremic syndrome, all leading to more or less the same pattern of endothelial cell damage, which will trigger a thrombosis. Of course, you have STAC HOS triggered by Shiga toxin secreting bacteria, pneumococcal, and you have some more special types of hemolytic uremic syndrome due to genetic defect in the metabolism or the physiology of endothelial cells, for example, DGK epsilon or cobalamin C deficiency. And of course, what we are interested in today is atypical HOS, which is a form of thrombotic microangiopathy and a form of HOS created or triggered due to a dysregulation of the complement alternative pathway. And during the last decade, atypical HOS has been a very successful story of translational research. We started with a very rare disease, incidence around 0.05 per million per year, and there have been a body of work that helped us refine our understanding of the presentation and outcome of hemolytic uremic syndrome, especially atypical HOS. As you see here, you have the classical triad that you all know: thrombocytopenia, microangiopathic anemia, and acute kidney injury. But when we go into the details, for example, thrombocytopenia may be missing in 15% of cases, which is a sharp contrast with TTP, for example. Second, familial history is very rare in adults. It's around 10–15%. So the absence of familial history does not exclude atypical HOS. And in a significant proportion of patients, half of the children, 1/3 of the adults, you have a triggering event, mainly infection, that will lead to complement activation and ultimately to atypical HOS. And as we all know, this is a severe disease, as half of the children and roughly 3/4 of the adults require dialysis during the acute phase of the disease. And the outcome was worse in the initial, in the short and long term. And to make a long story short, roughly you have 2/3 of adults reaching end-stage renal disease within 3 to 5 years of follow-up. And what we knew is that plasma exchange did not have a very positive or very significant impact on the outcome of atypical HOS. This is a retrospective review of the data from the French registry, showing that high intensity treatment, meaning you had at least 5 plasma exchanges or less plasma exchanges or no plasma exchanges, it didn't make a big difference in the renal outcome, at least, of atypical HOS. And the problem is that not only patients lost their native kidney, they also lost frequently, up to 50% of cases, their kidney graft due to the recurrence of the disease. So this disease, rare, but has been the focus of very intense clinical, genetic, and basic studies that have shown that ultimately the atypical HOS is a defect in the regulation of the alternative pathway. To make it short and to give a clinical perspective of what is a complement alternative pathway, you have 2 key enzymes. You have the alternative C3 convertase here and the alternative C5 convertase here. The alternative C3 convertase degrades or activates C3 to liberate C3b. And when C3b deposits at the surface of endothelial cells, it tags the cell for destruction. But the destruction requires the activation of C5 due to the alternative C5 convertase, leading to the assembly of the membrane attack complex that will lead to the lysis of the cell. Endothelial cells are in close contact to circulating components of the complement. This is probably why endothelial cells are so susceptible and frequently the victim of uncontrolled complement activation. And to control this system, you have 3 main inhibitors that will help protect the organism, the normal cells of the organism, of complement activation, for example, triggered by infection. So you have factor H and MCP, one circulating, one membrane-bound protein that will bind C3b and help factor I, the third inhibitor, to cleave C3b. So the protection of normal endothelial cells rests on the removal of the tag given by C3b. Beyond C3b, you have no much control. So you have to control your complement and protect your endothelial cells at the level of the C3b tag. And all the studies has led to the discovery that constitutional dysregulation of the alternative complement pathway is present in roughly 40 to 60% of patients. This dysregulation, it's due to mutation or variants in factor H, factor I, MCP. This is loss of function variants in the 3 main inhibitors of the alternative pathway. And you may have also gain of function mutation or variants in the 2 main components of the alternative C3 convertase, which are C3 and factor B, which means that you have roughly 50% of patients who have primary atypical complement-mediated atypical HOS without proven complement constitutional dysregulation and without variants in complement genes. And as you see in this picture, the outcome of patients depends also on the presence or absence of the complement gene variant, the worst prognosis being for those who carry a factor H variant. So this studies led to the design of a new treatment, specific and efficacious treatment for atypical HUS, which is C5 blockade. If you switch off C5 activation, you do not have any assembly of the membrane attack complex, so you don't have any complement-induced endothelial cell damage. And based on prospective non-randomized studies and retrospective series, we now assume that the risk of end-stage renal disease after in atypical HUS patients, adults at least, has dropped from 50 to 60% down to 10-15%. So it's a big move in the good direction towards improving the renal outcome, which is the main outcome. I'll go back to this a little bit later of atypical HUS. So, as you know, the first anti-C5 antibody which was approved is eculizumab, that prevents the inhibition, the activation of C5 by the C5 alternative convertase. And you have several studies. I have shown one here that in patients with atypical HUS who do not receive anymore, who did not receive at all plasma exchanges, you have a nice increase in platelet count starting within 10 days of start of treatment. But most importantly, you have also an improvement in kidney function, because in atypical HUS, unfortunately, hematological remission alone does not allow, is not a guarantee for a recovery of renal function. And as you see here, more than 80% of patients who are dependent on dialysis at diagnosis were weaned from dialysis after the start of eculizumab. And this goes back to what we said, that roughly we have still 10 to 15% of patients that still reach end-stage renal disease, probably because they have so intense damage in the kidney that it's too late to see an effect of eculizumab. But eculizumab and C5 blockers have also changed the perspective for renal transplantation in patients with atypical HUS and in patients at high risk for recurrence, especially those for variants in factor H, C3, factor B, and to some extent factor I. When you use prophylactically eculizumab at the time of renal transplantation, you have no recurrence and you have a perfect survival of renal transplant. But I must highlight that a very nice approach has been used in the Netherlands for patients with atypical HUS who require transplantation. They do not use prophylactic C5 blockers. They instead use living donation in order to decrease the period of ischemia reperfusion and thus reduce the ischemia reperfusion induced or triggered activation of complement that will lead to recurrence of atypical HUS. So this is the general regimen of eculizumab in clinical practice, 9 milligrams per week up to 5 weeks, and then every 2 weeks. And of course, when you start messing with a very old and conserved system like complement, you have infectious risk. I'll go back to this a little bit later. And of course, you have to discontinue plasma exchanges, otherwise you're going to remove and clear all the infused eculizumab. And one has to be patient because platelet count normalization occurs at a median time of 8-10 days. So a little 2 points about infectious risk with eculizumab. As you know, you have patients who have genetic deficiency in C5. They have no C5, and they have 1,000 increased risk, 1,000-fold increased risk of meningococcal infection. So before starting C5 blockers, we do vaccination against meningococcal. But you have to keep in mind that not all patients respond to vaccine, especially those with significant renal damage or those on immunosuppressive for renal transplantation. And even if you produce antibodies against meningococcal strains, if you don't have active C5, those antibodies are not prophylactic. That's why we always recommended the use of antiprophylaxis during the whole period of treatment with C5 blockers. This breakthrough in our understanding of atypical HOS have also led to clinicians to reconsider the physiopathology of other forms of HOS. The most illustrative example is pregnancy and postpartum HOS. As you see here, we have conducted a European study. You have a Spanish study also, and other data from other countries showing that HOS occurring in the postpartum and the peripartum period is complement-mediated atypical HOS triggered by pregnancy. The big problem is how to differentiate HOS in this setting from other forms of complication of pregnancy, especially preeclampsia, eclampsia, and HELLP syndrome. They may easily mimic HOS. I'll go back to this a little bit later. So I will spend a couple of slides on anti-factor H autoantibodies associated hemolytic uremic syndrome, because as you all know better than I do, it's a big problem. It's one of the main causes of atypical HOS in India. When you have autoantibodies that inhibit factor H, you lose the control of the alternative pathway. It's a disease that predominantly affects adolescents for unknown reasons, and more rarely adults. And in my point of view, it is an autoimmune form of atypical HOS and should be treated as any other form of autoimmune disease using immunosuppressive drugs, as illustrated here by the very nice data published by Arvind Baga from the Indian HOS Registry. Especially in countries where anti-C5 therapies are not available, if you have an initial autoimmune driver of the disease, you should clear the disease using immunosuppressive drugs, cyclophosphamide, MMF, rituximab, and plasma exchanges. But other countries, who have access to eculizumab and anti-C5 blockers, they do not use immunosuppressive drugs. They only use eculizumab and wait for the titer of the antibodies to decrease. So there is no universal truth. And for example, in France and Switzerland, we use a combination of the three depending on the severity of the case. We do plasma exchange, eculizumab, and immunosuppressive drugs in patients with heart involvement, for example, very severe heart involvement. In other cases, some clinicians will do only plasma exchanges. So if you want to discuss atypical HOS in terms of diagnosis and management, we have to distinguish two distinct phases. You have the induction phase, acute phase, and the maintenance phase, and each phase has its own issues and questions. In the acute phase, emergency phase, the main issue is how to be sure that you are dealing with complement-mediated atypical HOS. In other terms, how do we diagnose complement-mediated HOS? Unfortunately, all the biomarkers that we have are not fully reliable. For example, you take C3, C4 levels, they are normal in a significant proportion of patients, including in those with complement gene variants. For example, half of the adults and children with factor H variants have normal C3. Nevertheless, if you have a patient presenting with HOS and persistently low C3, well, it is an argument towards the fact that it is complement-mediated atypical HOS. You have more other biomarkers of complement activation, for example, soluble C5b9, but once again, their clinical usefulness has not been fully proved, and you have a very significant overlap between normals, active HOS, and HOS in remission. That's why some teams, some groups have developed in vitro assays to test whether a TMA or a form of HOS is complement mediated. Basically, you have endothelial cells in culture, dermal microvascular endothelial cells. You incubate them with serum from a patient with TMA. And if you see a lot of deposition of complement at the surface of endothelial cells, and when we speak about complement deposition, it's mainly C3c and C5b9. Well, if you have a lot of deposits, you will tell the clinician this patient has complement-mediated TMA. Unfortunately, these tests are not fully has not been fully duplicated. They have a huge variability, and some groups have not even managed to implement them. So they are not ready for implementation in clinical use in routine. So how do we diagnose currently atypical HOS? Well, it remains a diagnosis of exclusion. You will start by excluding all the other forms of HOS or TMA in adults, and you are left with atypical HOS when you didn't when all the other diagnoses have been excluded. So the main diagnosis, especially for hematologists, of course, is TTP, and it relies on the measurement, mainly on the management of a plasma ADAMTS13 activity, which is the cornerstone. But I'll go back to this a little bit later. But the main differential diagnoses are TTP, Shiga toxin-induced HOS, pneumococcal infection-induced HOS to some extent. You have cobalamin C deficiency, and what we call secondary HOS due to autoimmune disease, cancer, drugs, and several conditions, associated conditions. And in our recent paper in Blood, we gave the minimal test required for the differential diagnosis of HOS. Of course, plasma C3, and when available, factor H and factor R. And of course, if you have a patient with HOS and very low C3, which is, well, it's a big argument towards this diagnosis of complement-mediated HOS. Tests for anti-factor H antibodies, especially in countries where prevalence is high, and also because it has a very important implication for the management of patients, especially in terms of the use of immunosuppressive drugs, and measurement for ADAMTS13 activity. Well, it is not available everywhere, and even in countries in Europe, it's not available, rapidly available. So you can rely on some scores. You have mainly two scores. You have the plasmic score and the French score, and I use a modified French score. And if you have a serum creatinine below 2.2 milligrams, platelet below 30, and urinary over protein creatinine ratio below 1.2 gram per gram, well, these criteria are highly suggestive of ADAMTS13 deficiency as opposed to complement-mediated atypical HOS. The other tests are PCR for Shiga toxin in the stool, plasma homocysteine to rule out cobalamin C deficiency, and tests for autoimmune forms of HOS, mainly lupus and antiphospholipid syndrome. And I have added tests for monoclonal gammopathy because there has been a form of HOS associated to monoclonal gammopathy, and that may respond to eculizumab or C5 blocker. So this is a minimal test, but it's still, the differential diagnosis is still very difficult for atypical HOS because we don't have a reliable positive diagnostic test. So The differential diagnosis is difficult, especially in two situations. Pregnancy is the first situation. And we published 3 years ago in Blood, a series of recommendations and advices to help clinicians distinguish HOS, atypical HOS, from the by far more frequent causes of TMA or TMA-like disease in practice. And I will just discuss 1 or 2 points. The first is that preeclampsia, eclampsia are by far more frequent than atypical HOS and TTP. This is the first point. The second point is that in the absence of cardiac or neurological involvement, you can afford just monitoring the patient in an intensive care unit just to see how hematological and renal parameters will evolve spontaneously. And third point is that the benefit of plasma exchanges is only proven in ADAMTS13 deficiency related TTP, especially of course in the acquired form due to autoantibodies. In all other forms, the benefit of plasma exchanges is not very well proven or not proven at all. The second situation is a patient presenting with malignant hypertension. This is a difficult situation because malignant hypertension due to essential hypertension may be complicated by TMA and HOS in a minority of patients, less than 5%. And on the other hand, atypical HOS may present as malignant hypertension in more than 50% of cases. So we proposed several features that may help us distinguish one from the other. And I'll take a very illustrative example. If you have a female patient, age 30, with no history of hypertension, no left ventricular hypertrophy, who presents with HOS requiring dialysis and low C3 plasma level, well, it is atypical HOS. It's not essential hypertension leading to TMA. But still, this is a very complicated situation. So how do we manage in the acute phase? In the acute phase, you do the minimal test, you calculate your modified French score, and if you have a modified French score above 2, if you have an increased troponin cardiac dysfunction or neurological syndrome, you start plasma exchange. This is an ideal situation where ADAMTS13 testing is more or less easily available. And second, the algorithm I'm showing integrates the availability of C5 blockers. And I acknowledge that it's not available everywhere, but this is the ideal situation. And we adapt to what we can do in each setting. So you start plasma exchanges until you get ADAMTS13 activity, and you do your workup for differential diagnosis of atypical HOS. If everything is ruled out, in an ideal world, you stop plasma exchanges and switch to short-acting C5 blockers. If you don't have C5 blockers, you will keep going into plasma exchanges. And I have to admit that you have a minority of patients, around 10%, with clearly atypical primary atypical HOS. They do respond to plasma exchange alone, but you are missing the vast majority who will not respond, not only in terms of hematological remission, but also in terms of renal function improvement. So this is short-acting C5 blockers, and you will wait for 10 days. If you have a hematological remission within 10 days, it's okay. If no, you have to reconsider the diagnosis of atypical HOS, and you have to check for complement inhibition using mainly CH50 below 20%. And if you have a hematological remission, you will also want to have an improvement in renal function. Once again, hematological remission is not enough, because before the era of C5 blockers, patients who went into dialysis sooner or later had hematological remission but remained on dialysis. So if you have no improvement, you may consider doing kidney biopsy to assess the extent of fibrosis in the kidney. And once again, as your atypical HUS diagnosis was only made by exclusion, you have to reconsider it if the evolution is not in the right direction. This is the induction phase. But let's move to the maintenance phase, where the main question is when, in what patient can I discontinue C5 blockade? To make a long story short, we have several retrospective series, and we have one prospective series trial that has assessed C5 blocker discontinuation in patients with atypical HUS. Well, I'm very aware of the fact that discussing discontinuation of eculizumab, for example, in settings where it is not available already in the acute phase is not very helpful, but this is what we have. This is our current understanding in an ideal situation of atypical HUS. And the main message is that the risk of relapse of primary complement-mediated atypical HUS after C5 blockade discontinuation depends in a very predominant way on the presence or absence of complement gene variants. If you have no complement gene variants in adults, no relapse. When you have complement gene variant, you have a relapse. For example, 30-40% in MCP patient, up to 50-60% in factor H patient. And the only child who had no complement gene variant and who relapsed after eculizumab discontinuation turned out not having atypical HUS, but constitutional ADAMTS13 deficiency related TTP. So, in an ideal world, you have atypical HUS, you start your C5 blockers for 3 to 4 months, you get genetic workup, and the genetic workup will tell you if you have a variant, and especially it will tell you if the variant is pathogenic or not pathogenic. And this is a very important point, because detecting a variant is not enough. You have to know whether this variant is pathogenic or not pathogenic. The second point is that unlike all other genetic disease we are dealing with, for example, in hematology or in nephrology, including PNH, for example, not all patients with atypical HUS and not all carriers of complement gene variants develop the disease. The penetrance is rather high, and within a family, you may have 2 affected children carrying the same complement gene variant, and one of the parents carrying the same variant, but he or she will spend 90-100 years without developing any form of atypical HUS. So, if you have no complement gene variant, in my point of view, you can discontinue C5 treatment. If you have complement gene variant, it's a case-by-case basis, and it's a patient decision, which is important in this situation. So, what about other forms of TMA? The availability of all these C5 blockers have changed the perspective in the treatment of several forms of TMA and HUS. And as you know, TTP and atypical HUS are rather rare forms of TMA. The most frequent forms are secondary forms, especially if you include a pregnancy-related TMA, including preeclampsia, eclampsia, and HELLP syndrome. So currently, one of the main questions is to determine what is the spectrum of complement-mediated TMA. In other terms, in what forms of TMA is C5 inhibition or complement inhibition beneficial? So how do we assess the complement dependency of a TMA? Well, you have the frequency of rare pathogenic variant complement gene. You may have biomarkers of complement activation, low C3, increased soluble C5b9. You have the response to anti-C5 blockade and the relapse rate with or without treatment. And when we apply these criteria to secondary TMA due to, let's say, cancer, drugs, autoimmune disease, well, you do not have a very definite answer regarding the implication of complement. Rare complement gene variants are very rare, below 5%, and one has to keep in mind that the healthy population, the healthy individuals, you have around 3 to 5% who carry rare pathogenic variants in complement gene, and they did not develop or will not develop any forms of TMA. Biomarkers of complement activation have not been fully studied in secondary forms. Response to anti-C5 blockade, while available data shows that it is not straightforward like in primary complement-mediated atypical HOS. And finally, the relapse rate is very low, below 5%. That's why in our recent paper in Blood, we advocated the use of C5 blockade in very peculiar situations. The first is drug-induced, for example, gemcitabine-induced TMA, when probably eculizumab will help you achieve at least hematological remission. And the second situation, it is HOS or TMA due to autoimmune disease, in which the role of complement activation is obvious, like lupus, antiphospholipid syndrome, and to some extent, dermatomyositis. So where are we heading in the field of atypical HOS? And this is of interest, especially in countries where C5 blockers are not available. As you know, the main driver of the disease is not C5 activation. It is C3 convertase here dysregulation. And the most logical approach is to control and to restore a normal control of the C3 alternative convertase. So today it is C5 the main target, but one may say, well, why not inhibiting only C5a? Do we have to inhibit also C5b? And as you know, we have an orally available antagonist of C5a, but animal data indicates that C5a blockade is not enough. So the second step is to restore the control of the C3 convertase. And currently you have here a non-factor B drug that is tested in forms of atypical HOS. So factor B is a stabilizer of the C3 convertase. So if you inhibit a stabilizer, you will accelerate the degradation and increase the instability of C3 convertase. So you will decrease the activation of the complement alternative pathway and ultimately C5 activation. This is an important approach in the treatment, not only in the acute phase, but also in the maintenance phase. But unfortunately, today, you have trials with anti-factor B taking place, including in India, and you have several agents that target C5s that are available. They differ in terms of efficacy, way of administration, half-life. For example, ravulizumab is given every 2 months. Crovalimab is given sub-Q twice a week. But the most important thing is price. These drugs are extremely expensive, and probably the availability of biosimilars will help ease the pressure and may help some countries have a more easy access to C5 blockade. This is, as I told you, where we are heading. We are this main driver of atypical HOS. Once again, it is the C3 convertase dysregulation. It's not C5 activation. C5 activation is not only the consequence of C3 convertase dysregulation. So in conclusion, atypical HOS was a therapeutic issue. And as you remember well, 20, 30 years ago, we all used to treat any forms of TMA, whether it is TTP, HOS, or secondary HOS, with the same tools, starting with plasma exchange, plasma infusion, splenectomy, cyclophosphamide, vincristine, all the heroic treatments we used to use. Now we have a treatment. So atypical HOS has become a diagnostic issue. How to be sure that we are dealing with complement-mediated atypical HOS, and the quest continues for a reliable positive diagnostic test. And atypical HOS has also become a semantic issue. What do we call atypical HOS? A secondary HOS should be called complement-mediated atypical HOS. So even the term of HOS is controversial, and do not all agree on the same definition of HOS. And we do not all agree, for example, between Europe, US, and other parts of the world about what is atypical HOS. And C5 blockade has radically transformed the outcome of atypical HOS. This is obvious. However, the access to C5 blockade is not available everywhere, especially due to the very high cost of this disease, of this treatment. And we have now new approaches, I would say more close to the pathogenesis of the disease, targeting the which aims to restore a normal control of the alternative C3 convertase. Thank you for your attention, and I would be more than happy to answer your question if you have any.
Thank you so much, sir, for a wonderful lecture. What a sail through this difficult topic of atypical HOS. You have made it really easy and very easy to understand.
Thank you.
Now we have some Indian colleagues who are going to bother you with some questions, sir.
Yeah.
So we have our discussions here. To start with, we have Dr. Samin Belinkri, sir. Dr. Samin Belinkri, sir, your question, please.
Thank you, Dr. Fadi, for a very lucid talk. My question is, in India, where we don't have access to C5 blockade, as soon as we establish the diagnosis of an atypical HUS, typically we do the anti-factor H antibodies, and if if that is positive, of course, then we would go for plasma exchange and immunosuppression. But then we also do an MLPA to diagnose the common mutations in the complement regulators, and then subsequently an NGS, for the rarer ones. So in the event that we do an MLPA and we do find, a mutation in any of the prominent factors, would an emergency liver transplant be one of the treatments, which is probably going to be cheaper for us than to procure, eculizumab? And so my other question is, of these, are all the complement regulators produced in the liver, and would it make sense to do a liver transplant? Because that is available, emergency liver transplant is available in India.
Thank you for this very interesting question. Yes, factor H is synthesized by the liver. Factor I also. MCP is present on all the cells, so it is synthesized within each cell. I have to admit that the initial experience with liver transplantation, especially for factor H, was rather disappointing in Europe, because we had some loss of liver function and death of some young patients. We currently, since 15 years, I am not aware of any case of liver transplantation. So if in countries where C5 blockers are not available, yes, it is an option. I can't see the opposite. Yes, it is an option. But it is a risky option, I have to admit, because transplantation by itself will trigger complement activation. And what we saw initially, sometimes you have some delay before the liver transplant starts producing factor H. And this is what the initial problem. Putting aside all the infectious complications and everything. Yes, it is an option where put the patient on dialysis, get a hematological remission, and then consider liver and kidney transplantation. That's what we do for.
Thank you.
But in emergency setting, I'm not aware, even in the period before the eculizumab availability.
Thank you, Dr. Samir, sir. I have a question for you, sir. Suppose we have a patient of 45 years, female patient, who come to you with a acute renal failure and hemoglobin of 4.5 grams, suggestive of hemolytic anemia with full of fragmented cells on the peripheral smear, suspected atypical HUS, and NMTS 13 level of 23%, how would you investigate upfront for such cases to come to a diagnosis of atypical HUS?
At NMTS 13, you told me
23%.
Okay. 45 year, if I exclude lupus and antiphospholipid syndrome, I will treat her as atypical HUS.
So all investigations, what you said, should be done for all these cases?
Yeah, as I said, I showed on a slide, it's C3, factor H, factor I, okay? She has no diarrhea, let's forget she got toxic. And 45 female, I would go for antiphospholipid to check out. And obviously, she has no cancer. I would go for atypical primary complement-mediated atypical HUS.
Thank you, sir.
Unfortunately, yes, I gave a perspective, especially based on experience where eculizumab is available. And unfortunately, it's not available everywhere. And for example, in countries where it is available, we are now discussing whether plasma exchange should be the first step, first-line treatment of any TMA. Should not we go directly for caplacizumab or eculizumab? So unfortunately, no, it's not the same discussion everywhere.
Thank you, sir. Dr. Aditya Bartake, question, please.
Thank you, Dr. Padi. It was an excellent lecture. I wanted to ask, you talked about secondary TMAs, and sometimes we come across situations, post liver transplant, we see TMA, although it's rare, then it becomes, sometimes difficult to manage. Is there any role of C5 blockade there, and how would you approach such patients?
Yeah, in some forms of secondary, yes, we do use very short-term treatment by C5 blockers. For example, gemcitabine is a very good example. Gemcitabine TMA, if you stop the drug and you do not have at least hematological remission, we usually go for 4-6 infusions of eculizumab, at least to induce a hematological remission. Yes, even if you don't have a definitive proof that it is 100% active, as a salvage therapy, we do it in some forms, especially drug-induced. For the CNI, I have to admit, CNI usually, they go into remission when you stop CNI or at least reduce the dose. So we don't use it a lot in CNI-induced TMA, but in chemotherapy, yes.
Thank you.
Thank you, Dr. Aditya. One question has come from the audience by Dr. Naresh Tayadi. He says that whether plasma exchange itself can cause low NMTS 13 activity?
No. Does plasma exchange decrease? No. It can increase it, but no, it can decrease.
Another question is, whether do you require every patient of atypical HUS to be proven on kidney biopsy?
No. It is differential diagnosis is not based on kidney biopsy. We do kidney biopsy just for two reasons. The first, in the acute phase, is to rule out another diagnosis, for example, lupus, cryoglobulinemia. And when we feel that the kidney is not responding perfectly to C5 blockade, we do a kidney biopsy to see what is left of normal kidney. If the damage is not too important to hope for any recovery, even with C5 blockers.
Thank you, sir. Dr. Aditya, you have another question?
Yeah. So for children, as we say in India, like the CFH antibody-mediated HUS is a little more common, and they do respond to immunosuppression, as you mentioned. So in the long term, is there any preferable agent like either rituximab or mycophenolates, steroid-sparing agent, or is there any preferred agent for immunosuppression?
No, I think the most powerful one is cyclophosphamide, like you do in India. In Europe, we have tried rituximab, but rituximab takes longer time to act than cyclophosphamide. So the choice is between cyclophosphamide, and MMF as induction or maintenance therapy. You can do as in lupus, you can do cyclophosphamide as induction and use MMF as maintenance.
Okay. Thank you, Dr. Aditya. You have another question, Dr. Aditya?
Yeah, just one more thing. So many of these patients, those who develop antibodies, they also may have underlying CFH duplications. So does that affect the length of immunosuppression? Would you immunosuppress?
No. It depends on the title. We should take into account the title and the evolution of the title of anti-factor H antibodies too, like ADAMTS13 antibodies or anything else. No, it's based only on this.
Okay. Thank you.
Thank you, Dr. Aditya. Dr. Samir sir, you have another question?
Yeah, this is regarding the role of kidney biopsy once again. So sometimes, as you had mentioned, the platelet count tends to be just very borderline, just slightly low, and the kidney damage again is the creatinine is just borderline, and you're not very sure, we're not very confident. Just an occasional fragmented RBC in the peripheral blood, so you're not very sure whether you're dealing with an HUS or not. In this situation, would a quick kidney biopsy help in aiding the diagnosis?
Yeah. I agree with you. Totally agree with you. Especially in situation where thrombocytopenia is not very profound. And as I said, 15 patients of 50% of patients with atypical HUS have normal platelet count. That's why in our last paper, we proposed that kidney biopsy feature be included in diagnostic criteria. Because sometimes you have normal platelet, you have just some schistocyte on blood smear, some level of acute kidney damage, but the diagnosis rests on kidney biopsy. It's always better to see an image of TMA somewhere to be sure of the diagnosis, especially if it's not full brown. If you have 90,000 platelets, 600 micromoles or 9 milligrams of creatinine, it doesn't change a lot, but some TMA somewhere. I agree with you.
I had another question. You had mentioned in that algorithm where you would do the workup, the genetic workup, and if you find a mutation, then you may want to give indefinite C5 blockade, and if you don't, then 3 to 4 months later you may decide to withdraw it. So supposing you do find a mutation, and we know that sometimes for years they have not developed HUS, and then some triggers it off. So if you remove the trigger and you've given 3-4 months of eculizumab, and then everything is okay, can you afford to just wait until the next trigger comes? Can you monitor closely and see? And at the instance of any new possible trigger, you quickly work up and then again restart the complement black. Is that
Yeah. That's what we do.
because of the cost? Okay, you do that.
That's what we do. But some patients are very reluctant to stop.
Yeah.
If you have a family who had a very bad experience with 2 family members before the C5 blockers era. No. Even in our prospective trial, half of the patients. No, we do it, we inform them, and you have a very close monitoring, especially during infections, and you restart treatment. I agree.
Thank you.
Thank you, Samir sir. One question has come up from the audience that whether in a case of TTP, can be without thrombocytopenia also? You see lots of fragmented cells on the peripheral smear. It can be TTP? Only hemoglobin is low, LDH high, fragmented cells, and platelet count absolutely normal?
I would say so for atypical HUS without thrombocytopenia, but TTP without thrombocytopenia is very, very rare. No. I don't think it applies to TTP. It applies to some minority of cases of atypical HUS, but TTP, it's an exaggeration. No.
Thank you, sir. One question again from Dr. Naresh Tayade. What is the role of LDH in diagnosis of HUS if level of LDH correlates with severity?
No. Yeah, you have in hematology, as you know, you have very old data showing that the quality of response to plasma exchange, for example, in TTP. Now, in HOS, it is usually mildly increased, and sometimes it is still around 1.5, 1.8 upper limit of normal, even under eculizumab or everything else. The globin LDH has no prognostic value. No.
Thank you, sir. Dr. Aditya, you have another question?
Yeah. So regarding pregnancy associated or eclampsia associated TMA, like many times we find out that we rule out TTP by documenting normal ADAMTS13 level. Then differentiating between atypical HUS and eclampsia or pregnancy associated TMA, is there any biomarker easily available?
No.
No.
No biomarker, no. Sometimes we rely on the FLT1 over PLGF ratio, but a very easy one. I would say the best biomarker is how platelets and creatinine evolve during the first 48 hours. If you see a spontaneous trend towards improvement without any treatment, it points towards preeclampsia and eclampsia. But we don't have any biomarkers except FLT1 over PLGF. But yeah, no, it's just the evolution that will tell you.
So once the ADAMTS13 level is okay, we should not consider plasma exchange.
In my point of view, no. But I know it's a very stressful situation.
Yes.
And we do want to do something. And sometimes we do plasma exchange more for the anxiety of the doctors than of the patient. It's very stressful. You have a young patient, a new mother. It's not easy. Correct. But honestly, in all other cases, it's not a waste of chance if you do not do plasma exchanges.
Okay. Thank you.
But I know the pressure may be too high.
Yes.
Thank you, Dr. Aditya. So, anybody has any other question for Dr. Fadi? Yeah, Dr. Sushil Selvarajan, your question, please.
Yeah, thanks for that lucid talk. I just wanted to discuss one case. It's a very rare case. We had this 5-year-old boy with gain of function complement factor B, and basically presented with ESR, end-stage renal disease with atypical HUS. So we were working up, and finally, I mean, the data that we found was that both the pediatricians and us, we felt that the best option here would be a combined liver-kidney transplant. So, I mean, however, because of lack of liver donor, we went ahead with the kidney transplant and immunosuppression option. Eculizumab, we managed to give a few doses and then we managed. But in retrospect, I mean, child is doing well right now. But now, you know, for the long term, because he's had 2 recurrences of TMA after the transplant also. So we are wondering, in retrospect, should we have really pushed for this combined liver kidney transplant in this scenario? I'd like to get your opinion of that.
I would say no, especially if you had even a limited access to eculizumab. Because when you take the historical data, the recurrence occurred mainly during the first 6 months and during the first year, more or less, because it was triggered by ischemia reperfusion. If you are outside this period and the patient doing well, honestly, we have almost abandoned combined transplantation. There's no more any center. So we don't have any recent experience, but I think it is risky. I presume it was living donation.
Yes, you're right.
Yeah. Especially you did what the Dutch do, even in adults, they do living donation without eculizumab, and they have very nice data. Some of them relapse, but they respond to short-term eculizumab. Honestly, we do not consider same setting. I agree with this, but especially in this situation, I would not go for combined transplantation. No.
Thank you.
Thank you, Dr. Sushil. Anybody else? Any other question for Dr. Fadi?
One quick question. Do they have more thrombotic risk as we see in TTP? And
No.
should we do anything about it?
No, no. We had, especially in children, more problems related to vascular access for plasma exchange, but things have changed. No, it's not a big problem. No.
Thank you. So anybody else? I've finished all the questions from the audience. Well, in that case, if no other questions, thank you, Dr. Fadi, for that wonderful lecture.
Thank you for the invitation. It's always a pleasure.
And for a wonderful discussion.
Thank you, and thank you for
being
all
with
the
us
interesting interactions.
on this wonderful
Bye.
Sunday morning. Thank you
Have
so
a
much.
nice day. I'm gonna see my wife and kids before I'm gonna get killed. Bye-bye. Bye-bye.
Thank you.
Bye-bye.
Okay, bye.